Welcome to the NWATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Brian Wood to introduce our guest.
Great. A big thank you to Hillary Liss for coming and speaking today. Hillary has been kind enough to join us for a couple echo sessions, and we'll be giving a talk today on cervical cancer screening. And Hillary is a provider at our HIV Madison Clinic and Adult Medicine, and is Medical Program Director for the NWATC.
Thank you for having me here today to speak at ECHO. I'm going to be talking about cervical cancer screening and HIV, and I feel like this is a topic that tends to generate more questions than answers. There's a lot of conflicting information, conflicting guidelines. Hopefully we'll be able to untangle some of the mess. I just was actually sitting at our colposcopy clinic at Madison Clinic before I came over here, talking to the main provider who does colposcopies at Madison Clinic, and it was pretty amazing because as each resident came in to present their patients, repeatedly, this is a 28-year-old woman with HIV. This is a 45-year-old woman with HIV. This is a 60-year-old woman with HIV. So clearly our patients are having increased risk of cervical cancer and of cervical dysplasia. So I'm being a little ambitious today. We're going to talk about epidemiology of HPV and cervical cancer and HIV briefly, review cervical anatomy and HPV pathophysiology. We're going to talk about current cervical cancer screening guidelines, and really this is one of those topics that you have to talk as much about patients without HIV as you do about patients with HIV, so hopefully we'll be able to review a little bit of both the guidelines for patients with or without HIV. And we'll try and cover the topics below: when to start, when to stop, what to order and how often, what to do after a hysterectomy, which we discussed a couple of weeks ago at ECHO, the role of HPV testing, some special populations, particularly pregnancy and adolescents, and then what to do about follow-up of abnormal cytology, and finally future directions in cervical cancer screening. You may note that I left off HPV vaccine for two reasons. One is that Dr. Dan Reddy, I believe, has already given a talk about vaccines and STD screening, and as such, I know it's been covered elsewhere, and we have so much to cover today. And in addition, we don't have a lot of safety and efficacy data in this population. So first, we're going to talk a little bit about epidemiology. So cervical cancer is the 5th most common cancer in humans and the 2nd most common cancer in women. 190,000 women die each year worldwide, and the vast majority of these patients are in resource-poor settings. And cervical cancer is still the leading cause of death from cancer for women in these settings. Up to 50% of sexually active women in the U.S. Are HPV positive 36 months after starting to have sexual activity. And the prevalence at any given moment in the U.S. is thought to be about 57% in sexually active adolescent women. And again, for the purpose of this talk today, adolescent means less than 21. Resolution of infection occurs in about 90% of adolescents in 2 years, and that's in immunocompetent individuals. It is probably less common for that to happen in HIV-infected women, and there are studies that show that it usually takes maybe even another year for clearance, and that clearance of HPV tends to happen in less women. Women 50 years of age, 80% will have acquired genital HPV infection at some time in their life. What about HPV? Well, it's the most common sexually acquired infection in the world. It's a DNA tumor virus, and it causes an intraepithelial infection that can lead to squamous changes and adeno changes that will lead to cervical cancer and other cancers, and we'll talk about that list in a minute. There are more than 100 types of HPV, 40 of which can infect the cervix. 13 are oncogenic in terms of cervical cancer. 16, 18, 31, and 33 are the most common, but there are several others. 6 and 11 are associated with genital warts. HPV 16 causes 50% of cervical cancers, and then probably 10 to 15% of the rest of cervical cancers are caused by HPV 18. 6 and 11 account for 90% of genital warts. Recurrent infections are quite common, and we do have some available prevention. HPV vaccine, and again, safety and efficacy data is not yet available in women with HIV. There are some studies that have looked at HPV vaccine in infants and children who are perinatally infected. They did have excellent seroconversion rates, but their titers were lower than patients without HIV. Condoms have also been studied and have been effective, but they are not perfect. In terms of HPV and HIV, HPV is more persistent in HIV-positive women. I mentioned before that in adolescents it does not clear as quickly as in HIV-negative adolescents. Higher levels of HPV are detected in HIV-positive women, and that probably also increases risk of cervical dysplasia. It's very common to have multiple concurrent HPV infections from different types. The incidence rate of cervical cancer seems to be quite a moving target, and I saw rates ranging from 2 to 22 times higher in women with HIV compared to HIV-negative women. And just as a reminder, cervical cancer is an AIDS-defining condition, and cervical dysplasia is a B condition using our old staging criteria. HPV manifestations, or why do we care, is because it can lead to, as we mentioned, warts, cancer precursors, dysplasia of the cervix, the vulva, the vagina, and the anus. And it can also lead to multiple different types of squamous and adenocarcinomas, including cervix, vulva, vagina, oral cavity, penis, and oropharynx. I've clearly looked at that word too many times in the last few days. Okay, so in terms of HPV and cancer rates in the U.S., you can see that there are about 11,000 cases of cervical cancer in the U.S. per year. 96% or higher are thought to be related to HPV. Vulvar cancer is about 51%, and vaginal cancer is also about 50% are accountable to HPV infection. Anal infections or anal cancers in the U.S. are growing exponentially, and we already know that in men with HIV, the risk of anal cancer is about 60 times that of the risk in an HIV uninfected man. So really, really astounding risks in our population. And the rates are also increased in women, but at a lower increased rate than in men. I think that may change. Also, interestingly, cases of anal cancer in women have not always been associated with reports of anal sex. So it's thought that there's increased rates of anal cancer in women with HIV who have cervical dysplasia as well. Oral cancers, we've really learned a lot in the last few years how many head and neck cancers are related to HPV, and the estimates now are about 63% of head and neck cancers or oral cancers are related to HPV. So really impressive numbers. And I think this is just a tinderbox in this country in terms of how many cancers we may see related to HPV, especially because the only cancer on this list that we routinely screen for is cervical cancer at this point. The guidelines may change in terms of anal cancer and screening policies, but right now the only one we have a policy for is cervical cancer, and we have seen major, major improvements. It's really been a success story in terms of cervical cancer screening. But until we have screening protocols for anal cancer, I think we really could be seeing a lot more patients with these cancers. So briefly, we're going to review cervical anatomy and HPV pathophysiology. And so here's some definitions and anatomy. And again, I know many of you have seen this before, but when women are prepubescent, the cervix is covered with columnar epithelium. It's a single layer of columnar cells, quite vulnerable, really. And that's why we think that many young women are at such high risk for getting infections with STDs, including HPV. The columnar cells are gradually replaced by squamous epithelium starting in puberty, and that's called squamous metaplasia. So originally, the squamo-columnar junction is out here on the ectocervix. But then this area gets replaced by squamous metaplasia, and then the new squamo-columnar junction, the intersection between the columnar and squamous epithelium, moves up into the endocervix.
Thanks.
The transformation zone is the area of squamous metaplasia, and this is really a very important landmark in colposcopy because this is the most common location of neoplastic change in HPV-related changes. So here is a picture of a normal cervix, and this is actually on a colposcopic view. You can see some normal changes. They're called crypt openings. Here you can see the original squamo-columnar junction. It can be very subtle, as it is in this picture. And this is the original squamous epithelium on the outer aspect of the original squamo-columnar junction. And then this area is where we have the metaplastic squamous epithelium. The new squamo-columnar junction is now in the endocervix. You really need to see that whole area to have an adequate colposcopy. And in terms of HPV natural history, there are 3 steps that lead to cervical cancer. You have a normal cervix that gets infected with HPV. Over the next few weeks, you can have infection with HPV and have your first lesions related to HPV in probably about 1 to 8 weeks. Over the following year or 2, you can have clearance of the HPV. The HPV-infected cervix can have mild to fairly moderate cervical abnormalities and cytologic abnormalities. But again, most people regress, their HPV regresses, and they have no further problems. A small proportion, probably 10 to 20% in the HIV uninfected patients, have progression to a precancerous lesion and then invasion to cancer in a much smaller proportion. So what are the current cervical cancer guidelines? Different guidelines have different functions, and I used to hear about all these different guidelines, and I was so unbelievably confused that I just wanted to try and clarify this a little bit. In March of 2012, there were major announcements about new guidelines that were put out by the U.S. Preventive Services Task Force, and then a joint committee of the American Cancer Society, the American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology came out with guidelines that all were really in agreement, which is quite astounding for all these major organizations to agree. And those really focus on the age, the interval and frequency of screening, when to start, when to stop, how often to screen. Then there's also the ASCCP puts out consensus guidelines, and these interpret and give management recommendations for screening and colposcopy results. So when you get a result from your screening, as dictated by the first set of guidelines we mentioned, then those will tell you what to do with the results. And then finally, a very important set of guidelines, obviously, for our population is the OI guidelines, or the CDC OI guidelines, is what I will refer to them as for the rest of this talk. Those kind of address both of the aspects of cervical cancer screening I mentioned above. The ultimate goal of all the guidelines is cervical cancer prevention via screening, cytology with or without HPV DNA testing, evaluation of screen-positive women using colposcopy and biopsy, and then treating those women with biopsy-confirmed high-grade cancer precursors. And usually that's like CIN 2 or 3 is what we call high-grade lesions. In terms of frequency of screening in HIV, I think most people are familiar that you're supposed to do a Pap smear twice in the first year after entry into care or after diagnosis. And if both of these are normal, then annual screening with Pap smear. If abnormal, the follow-up will depend on the abnormality. You want to refer to colposcopy if any of the abnormalities below are found. Now, the tricky part is, what do you do with ASCUS? And we're going to talk a lot more about this, but this is where guidelines really are conflicting. So I tried to put everything in a table because I thought this would be helpful. These are cervical cancer screening guidelines, and really this column refers to women without HIV. What is very important for everyone to realize is the U.S. Preventive Services Task Force guidelines and then the new American Cancer Society, American Society of Cervical and Colposcopy and Cervical Pathology really refer to women who are lower risk. This does not refer to women who have had DES exposure in utero. This does not refer to women who are immunosuppressed or women who have had a history of significant dysplasia in the past. So in terms of age at initiation, in terms of HIV uninfected women, the guidelines say that you should start at age 21 regardless of risk factors. In terms of women with HIV, it's really quite hard to figure out from the guidelines. In light of the fact that these previous guidelines say they don't really apply to women with HIV, I'm assuming that they're not including the risk factor of HIV, and so when you look at other guidelines, they seem to suggest that we should be starting screening at the onset of sexual activity. Follow-up will be a little bit different in these women under the age of 21 because we try to be less invasive, and we'll talk more about that on the next slide. In terms of frequency, in women aged 21 to 29, you're supposed to do a Pap every 3 years alone in women without HIV, and you're supposed to do a Pap alone annually in women with HIV. In women whose age is greater than or equal to 30, without HIV, you can do a Pap every 3 years, but really the more preferred method of screening is doing a Pap plus HPV testing every 5 years. And that is said to be the preferred regimen. Women with HIV, no matter their age, need annual screening. Women without HIV can stop getting screening at age 65 if they've been adequately screened in the past, and that means they've either had 3 PAPs in the last 10 years or 2 PAPs plus HPV in the last 5 years, with the last one being negative. In terms of women with HIV, we really think you probably should never stop. Again, these guidelines may change, but the current guidelines would say that you do annual screening for life. After hysterectomy, you can discontinue in both women with and without HIV if the hysterectomy was done for benign reasons and there's no history of CIN2+ for the last 20 years. Otherwise, screen for 20 years after. In terms of HPV vaccinated women, there's really no change in guidelines. So what about screening adolescents with HIV? Well, there was a symposium that was brought together in 2009 of the major organizations that give guidelines, and really they said less is more. You want to start screening at age 21 regardless of risk factors. You want to never use HPV testing in adolescents and rarely intervene with colposcopy or any further invasive treatments unless someone has HSIL or CIN3. And the rationale is that all these increased procedures, and especially invasive procedures like LEAP and cone, run an increased risk of preterm delivery and low birth weight infants, and there's a lot of psychosexual dysfunction related to being diagnosed with HPV and going through these invasive procedures in young women. And again, there's very high rates of regression, even with CIN2 and 3 in adolescents. The problem is in HIV, as we mentioned before, the regression rates are lower, so there's more CIN, and so the recommendations have again been to start screening right away at the onset of sexual activity, and if there's any abnormality that's ASCUS or greater, that these women should go to colposcopy rather than just waiting and repeating in a year, which is the guidelines for women without HIV. You still want to reserve treatment for CIN3, and there's no role for HPV testing. So I know we're running out of time, but I'm going to go through a few more slides. I think this is a very common scenario a lot of us are running into. Oops, I ordered HPV and it's positive. So in women with HIV, the guidelines would say, well, the guidelines are unclear what to do. This is what the guidelines would say in a woman who's HIV uninfected. If you have a negative Pap and a positive HPV, you want to repeat both in 1 year. If they're both negative, you can resume annual Pap screening. If the Pap is negative and the HPV is positive, then you need to have a colposcopy. If the Pap is ASCUS or worse and any HPV result, you would manage per the ASCCP algorithms, which I'll show you in just a moment. So what is the role for HPV testing in women with HIV? In the general population, you can triage ASCUS. So if someone has an ASCUS Pap result, you reflexively do HPV, and if it's positive, you do a colposcopy. If it's negative, then you can resume routine screening. The ASCCP tells us we can do the same thing in the HIV population, and that is actually what we have elected to do as our clinic policy at Madison Clinic, with a lot of consultation with the OBGYN department. In the general population, you can co-test with Pap and HPV in women older than 30. That is not recommended in women with HIV because no matter what the results are, we're not going to extend screening to 3 years or 5 years at this point. That may change, and there is emerging data to show that we may be able to use HPV in the future, but the current guidelines say there is no co-testing. Postmenopausal women with LSIL, often we do HPV in these women who aren't HIV infected. I don't think I would recommend that in women with HIV. And then finally, follow-up after colposcopy or treatment procedure per guidelines. And so certain algorithms, depending on what the finding after an abnormal Pap, will suggest follow-up with HPV. Again, the ASCCP says we can do that. The key thing here is that per the CDC OI guidelines, they say we are never supposed to do HPV in these women. When you get your pathology results from your cervical screening, there's several different options of what you can see. You can get an inadequate or unsatisfactory sample, which would indicate that there was not enough cellular specimen to make an adequate reading of the Pap sample. In this case, if it says inadequate or unsatisfactory, you need to repeat the Pap smear at your next available opportunity. Obviously, you can get an abnormal result, and we'll talk more about what you do with an abnormal result. If you get a negative result, that may not be the end of the story, however. One thing that you could get is at the bottom of your Pap smear result from pathology, often you will get a comment in the comment section. Sometimes it will actually describe an organism that was present on the Pap smear. Sometimes it will say that there were candidal or fungal elements consistent with candidiasis. Generally, we don't treat based on that from a Pap smear, and I would recommend that you call the patient and find out if they were having any symptoms. But if you didn't see any discharge and the patient wasn't complaining of symptoms at the time of the Pap smear, I think in general we don't recommend treatment. Sometimes it will say a shift in the vaginal flora, which would suggest bacterial vaginosis. Again, generally, if the patient's been asymptomatic, we don't recommend treating based on that. The exception in this case would be if it says that there are evidence of trichomonads or suggestion that the patient actually has vaginal trichomoniasis. And in that case, if that is seen on your Pap smear, you do want to recommend treatment regardless of the patient's symptoms. In the past, we said that the patient needed to come back in and be retested and have a wet mount performed again to look for trichomonads. But studies have shown that if trichomonas is seen on a Pap smear, that indeed indicates infection with trichomonas and should be treated. There are other non-neoplastic findings that can be found on a Pap smear, such as atrophy, benign-looking glandular cells, and these need to be treated on a case-by-case basis. Finally, there can be squamous cell abnormalities, so this would be the abnormal results on a Pap smear. This could include ASCUS, and we'll talk about that in the next slide. It could include ASC-H, which stands for ASCUS, cannot exclude high-grade squamous intraepithelial lesion, and those patients should go directly to colposcopy. Or it could say LSIL or HSIL, which would be low-grade or high-grade squamous intraepithelial lesion, and those patients should be referred immediately to colposcopy as well. So what about ASCUS? Like I mentioned before, ASCUS is one of the more challenging aspects of Pap smear screening. There are conflicting guidelines. The 2006 ASCCP guidelines would suggest that patients with HIV be treated exactly like any patient without HIV and should be triaged based on HPV. Unfortunately, this conflicts with the CDC OI guidelines that say we never should be using HPV at all in HIV-infected women. The key things to know here is that ASCUS is very common in HIV. Up to 78% of women in a 4 to 5 year follow-up had evidence of ASCUS. This would mean that if we sent all of these women to colposcopy, we would be doing colposcopy procedures on almost all of our women with HIV. And with the limited data that we have, the ASCCP has said that HIV-infected women with ASCUS can be triaged as the same as uninfected women. This is in fact what we have decided to do at the Madison Clinic, and we feel that this is very reasonable, especially as these patients should be followed up annually. And fortunately, dysplasia tends to be slow growing, and we have not seen that if a patient is ASCUS HPV negative, that they have had any significant progression over the year. Some people would say that if a patient is severely immunocompromised, their CD4 count is less than 200, and they're ASCUS HPV negative, that these are patients that perhaps should go right to colposcopy, but we really don't have great data to support that. Here is just an example, again, of one of the algorithms from the ASCCP. These are excellent algorithms, and they are available for every abnormal Pap smear result, as well as for every abnormal colposcopy result. And the thing that you should know is that many of them use HPV as a follow-up test after an abnormal Pap smear. Again, just to be clear, according to the CDC-OI guidelines, we shouldn't be using HPV in any circumstance, but the ASCCP says it is okay to use HPV as follow-up testing for women with HIV, and I think that this is a reasonable plan. So just to walk through, if someone has ASCUS, if you do reflexive HPV DNA testing, if it's positive, you go right to colposcopy. If it's negative, you should repeat cytology at 12 months, repeat a Pap smear. Or your other option would really be to go right to colposcopy. In terms of managing pregnant women, we really want to avoid invasive intervention in pregnant women in terms of invasive procedures related to an abnormal Pap smear. The only finding that would affect management timing and the route of delivery of a baby is invasive cancer. And so the recommendation is that we can defer colposcopy for ASCUS and LSIL until 6 weeks postpartum. Immediate colposcopy should still be performed for findings of HSIL or atypical glandular cells, AGC, on a Pap smear. So what do we do about follow-up of abnormal screening? Most of the time we have to do a colposcopy, and again, this is going to be involving looking at the transitional zone, evaluating the extent of the disease with the application of acetic acid, locating the area that's most suspicious for biopsy, and then determining if invasive cancer is present. Depending on the results, you may need to consult the algorithms, or the patient may need to go on for further invasive procedures like a LEEP, a cone, or cold knife conization. Again, there's excellent algorithms to guide us, and they are not specifically for women with HIV, but very similar to the OI guidelines with the exception of HPV testing. I've put in a slide about strategies for improving screening rates. It's really important to educate our patients. It is a huge problem that women with HIV are not being properly screened for cervical cancer, and this was actually a major topic I heard at the Ryan White meeting last week. It's really important to educate our patients. A lot of them just don't understand what the role of Pap smears and cervical cancer screening is and their increased risk with HIV. Public health materials, face-to-face discussions can be very helpful, and this is a really fun slide of a campaign that we did here in Seattle, King County, How's Your Cervix? Also really addressing specific concerns and normalizing fear and embarrassment. We are really lucky that we have our case managers in clinic, and I have dragged Jennifer into a few of Pap smears with me. They haven't always gone so well, but I'm sure they went much better than if Jennifer wasn't there. It's also important to offer options for a female clinician if the patient is uncomfortable with a male provider, if it's possible. And then again, tickler systems, systemic processes to make it remind us to do cervical cancer screening. So what are future directions? Well, I think we're going to learn a lot more about the role for HPV testing in women with HIV, and we may be able to increase the interval for testing and spread things out a little bit. HPV vaccine efficacy data in women with HIV is still on its way. New HPV vaccines are being tested that are thought to cover 85% of HPV infections, and those we'll hear about more. More specific HPV tests for infection may be available that are more specific for actual precancerous lesions. Anal Pap guidelines may be on their way, and then better financial coverage for HPV co-testing should we get guidelines to say we should be doing HPV testing should be available soon, because when the U.S. Preventive Services Task Force says we should be doing HPV co-testing, we're obligated to pay for it with most private and public insurers. I think I'll end there. I know that this usually does raise a lot of questions in terms of cervical cancer screening. I'm totally open to hearing questions right now, or you can email them to us and I will be happy to investigate them. Thanks.